Welcome to this educational program and discussion on unraveling the complexities of angiogenesis inhibition in metastatic colorectal cancer. Welcome to Leuven. I'm Eric van Kutsen, professor here at the University of Leuven, and I'm happy to be joined by Professor Marc Ichou from Montpellier, France, and Professor Dirk Arnold from Freiburg, Germany. The goal of this meeting is that we have a lively interaction on really discussing the complexities of the processes of angiogenesis and discussing the weaknesses and the strengths of the different trials, so that we can offer you as clinicians or as scientists and researchers some insights in why in some patients we could go for certain treatments and where we have the evidence and where we lack some evidence in this situation on that. And what we will do is we will discuss some of the important first-line trials around angiogenesis inhibition and also some of the important data in second line because there in second line it's really an important challenge. We've seen some important new trials with important new classes of agents and new agents. And for the clinician, it's not easy because we lack really head-to-head comparisons in second line of the different anti-angiogenic agents. So we will try to discuss some of the strengths and the weaknesses in this situation. Let's start with some of the first-line trial. Mark, how do you see in first line the role of angiogenesis inhibition? Should we offer it to all patients? Which backbone should we use for anti-angiogenic agents in this situation? Which backbones of cytotoxic treatment?
We know the place of anti-angiogenic from the first trial, from Hervé's trial in 2004. And I remind that it was the first demonstration of the activity of an anti-angiogenic drug in cancer, and it was in first-line metastatic colorectal cancer. But from this time, we have also the story of the anti-EGFR therapy guided by the RAS mutation. And we know that the debate at this time exists for patients with wild-type RAS status, in which we clearly have the choice between two biologic, anti-EGFR or anti-angiogenic. For patients with RAS mutations, we have no choice, and in this case, if the patients have no contraindication of anti-angiogenic, we have now a lot of data supporting that anti-angiogenic, and it's bevacizumab for the moment, can be combined to 5-FU alone, intravenous or capecitabine, to big chemotherapy, either FOLFIRI or FOLFOX, and even to a triplet chemotherapy with a TRIBE study with FOLFOXIRI.
And Dirk, what is for you the optimal backbone of angiogenesis inhibitors in first line?
Well, that's a difficult question, as Mark said. It's comparable and it increases efficacy of first line single agent and also can be used, as we have recently learned, with triple chemotherapy and safely combined with triple chemotherapy. So I can't exactly say, although it's mostly used in doublets, and the only question which we're working on the last years is, it is clear in doublets for RAS mutant patients, the only take is how should we use it in RAS wild-type patient, and they would like to learn your position, how should we use it there? It is clearly, that's my take of the recent data, a standard, and we can discuss whether it should be the standard in these patients who use anti-EGFRs or also anti-angiogenic treatment. So there I would like to learn and to know from you, how do you see the data in the RAS wild type? Is it still a standard for these patients?
Yeah, I think it's still a standard. We also in our practice here in Leuven, we use it in the vast majority of patients unless there are contraindications. Because for us, the continuum of care through different lines, and we will discuss later on also second line, the continuum of care is important. Maybe a subgroup of patients where with liver-limited disease, where really downsizing is crucial, where we want to go for response in this group of patients, where the anti-EGFR antibodies may lead to a higher chance of a response. If these patients in RAS wild-type tumors, but in the majority of patients, it's clear a standard, and someone could even ask a question or make the statement that it's the standard in many of these patients.
Right.
The challenge is also to determine what is really the optimal backbone. Is it irinotecan based or is it oxaliplatin based? Which cytotoxic do you use most often in this?
Mostly, I'm personally a fan and a believer of the induction and maintenance treatment concept. And for a relatively short induction treatment phase, I prefer oxaliplatin over irinotecan. So I use one of the oxaliplatin regimen, mostly FOLFOX, but also Xelox in most of my patients in combination with anti-EGFR, so weaning with bevacizumab.
Yeah, that's also what we do. Do you do the same, Mark? Because I'm not completely sure, knowing you, that you do them many.
As you know, probably I prefer to use irinotecan and FOLFIRI. In the literature, we cannot conclude clearly because in terms of evidence-based medicine. But as you know, the only trial in first line that compared FOLFOX or Xelox plus bevacizumab versus FOLFOX or Xelox alone did not show any improvement in terms of overall survival. And a very short, low improvement in terms of PFS. So I agree that it depends on how you use the FOLFOX, and probably in this trial, the use of the oxaliplatin and the maintenance of bevacizumab alone with a 5-FU was not done. So probably it is equivalent to start with FOLFOX beva and to continue with 5-FU beva, or to start with FOLFIRI beva and to continue with 5-FU beva.
Yeah.
But that's my take of this year's data we do have, and wonder what is yours also, that given the wealth of data we do now have in our hands from the FOLFIRI bevacizumab, from the newer trials, meaning from the fire-free trial, and the whole range of data set we do have now from CLGB trial, that there is not much of a difference for me regarding to chemo.
Yeah, that's right. Another important and final question in first line is also, what about if you consider a patient who is not fit enough to go for a doublet cytotoxic, so you would give him 5-FU or capecitabine? Do you always combine this with bevacizumab in first line, or will you give capecitabine alone?
No, now, and it is supported by the results of the AVEX trial, which is very clear in elderly patients, but I think it can be reproducible for all patients that are not suitable to doublet chemotherapy. I think there is some data now supporting to combine bevacizumab to 5-FU alone, clearly, and Cabinavar trial also.
I completely agree, and I guess Dirk also agrees with that statement.
And even, excuse me, but if we look to all the data, it seems that the benefit of anti-angiogenic is maybe better. The delta and the difference between anti-angiogenic or no anti-angiogenic seem better with 5-FU alone than with the doublets.
Mm-hmm. The challenge is, or the field is much more complex in the second line. If you look at in the second line, if you look at randomized phase 3 trials, we have in fact 5 randomized phase 3 trials of chemo plus or minus a targeted agent. There's one trial with irinotecan plus or minus cetuximab, FOLFIRI plus or minus panitumab, and then there are 3 or maybe 4 trials with angiogenesis inhibitors. That's the ECOG 3200 trial in bevacizumab naive patients, which is not completely of application anymore in the majority of cases. But then the 3 other trials, the TML trial with post-progression continuation of bevacizumab, the ramucirumab trial, FOLFIRI plus or minus ramucirumab, and then the VALOR trial, FOLFIRI plus or minus aflibercept. In some of the trials, all patients were pre-treated with bevacizumab. In some of the trials, like the VALOR trial, 1/3 of the patients were pre-treated with bevacizumab, 2/3 not. How would you make your choice in second line? Because we don't have head-to-head studies of aflibercept versus bevacizumab versus ramucirumab, for instance. We know that they are all 3 active. The hazard ratio is similar, around 0.8. There is in the 3 trials a survival and PFS, progression-free survival benefit of adding the antibody, the angiogenesis inhibitor. Do you make your choice on the mechanism of action, toxicity, biomarkers, clinical patterns? Difficult.
Biomarker would be great.
That's not the case. By the way, why did we fail until now?
Well, I think it takes another educational activity to explain that in detail. No clear idea.
Yeah.
No really good idea. No, but I think most physicians would make the treatment decision on the inclusion criteria of the trial. Can we compare the patient we have in front of us with the patient which underwent treatment in the trial, and also in terms of efficacy and also toxicity, of course. And therefore, I think the key is, as you already outlined, that they all have different inclusion criteria. TML, for example, which we were in charge, both of us, was very artificial, reflecting some clinical practice, but artificially this is only limited to the patients which successfully were treated with bevacizumab and were not progressing massively, and also had a discontinuation of bevacizumab for 3 months. That's the most artificial. For me, the most open or most common practice trial is the VALOR trial, or are the inclusion criteria of the VALOR trial, because those patients had any pre-treatment with or without bevacizumab, and then just were put on the trial and had an overall survival gain by adding aflibercept. And the race with ramucirumab is somewhere in between. They had to have pre-treatment with bevacizumab, but it was not clearly ruled how long this had been and how long this had to be discontinued before. So those, for me, those differ in terms of inclusion criteria and also in terms of toxicity. What is your feeling in this?
Yeah, I think some of the aspects are right. I think the VALOR trial, 1/3 of the patients already were pre-treated with bevacizumab, 2/3 were bevacizumab naive. Today that would be a little bit different, but that was at the time the trial was done a couple of years ago. The hazard ratio went in the same directions. The number of patients was smaller in the subgroups of naive and pre-treated patients, but hazard ratio went in the same direction. We did tests for interaction. There was no interaction, meaning that there was a benefit of aflibercept in both groups of patients. So for me, clearly the patients with a fast progression, based on what you said, with a fast progression on a first-line FOLFOX bevacizumab, are probably rather patients, better candidates for FOLFIRI, aflibercept. Slower progressors are more candidates probably for bevacizumab. The challenge is, where is the cutoff of what is the definition of fast, what is the definition of a slow progress?
But were you, as one of the principal investigators of the VALOR trial, were you surprised to see the increase in response rate?
I was not surprised. I don't have a good explanation why it's seen in this trial and not in the bevacizumab and not in the ramucirumab trial. We did also the phase 1 study with aflibercept, where we had a large cohort of patients in the 1B trial pre-treated with FOLFIRI, and then we treated them with FOLFIRI aflibercept. And in this group of patients, we also saw tumor regression. So I was not surprised when I saw that. I don't have a good explanation why it is the case. The challenge, of course, the door opener is that people say, maybe PLGF, placenta growth factor, maybe VEGF-B plays a role, but In fact, nobody knows what is the real role of inhibition of PLGF, placenta growth factor. Nobody knows what is the role of inhibition of VEGF-B in this situation. So we don't have a good explanation, but the data are there.
And don't you think that it could have a link between the increase of in terms of tumor response and also the increase in terms of chemotherapy toxicity with aflibercept, because we have more diarrhea and more neutropenia, and clearly there are toxicity usual with FOLFIRI, but they are increased. And so maybe the mechanism of action is slightly different between bevacizumab and aflibercept.
It's sure that there is a different mechanism of action, and if you look in some of the knockout experiments in PLGF knockout mice, it's seen that also, at least in some experiments, that there is that this may be inhibition of PLGF may be the reason of the increased diarrhea. Not all preclinical scientists and fundamental scientists agree with this statement because there are some conflicting preclinical data. The fact also that it's slightly more toxicity may be also due, as Dirk said, due to the design of the study. Remember that in the bevacizumab study, post-progression, patients could start on a slightly lower dose of FOLFIRI. While in the aflibercept, the full dose of FOLFIRI had to be started, even if the patient was already dose reduced in the first line with 5-FU. So that may be also partly the
TML, the second line was more heterogeneous in terms of chemotherapy, because only some patients receive FOLFIRI, some over Xeluri, and some over irinotecan alone. So it is...
and most oxaliplatin anyway.
Yes, but I speak for the part, the irinotecan arm,
How do you decide in clinical practice? Because you have aflibercept, you don't have yet ramucirumab, but take that into account that also today we have ramucirumab, and we have bevacizumab in second line. How would you profile your patients, Mark? You don't have biomarkers.
No.
So how do you profile and how do you decide? Is it on economic factors or is it on clinical factors, or how do you do that in your practice in Montpellier?
The main factor for me is to select patients for whom I want to have the better chance to have a tumor response, objective response. And clearly, it seems that aflibercept increase the tumor response and not bevacizumab.
But how relevant is tumor response in second line?
Well,
because these are patients that usually are not resectable.
Sometimes patients have can be candidate for patients who have a mutation, a RAS mutation, and you have not access to anti-EGFR to increase the tumor response. Sometimes you have patients in second line, you can hope to have a secondary resection or to have an improvement in terms of symptoms due to tumor progression, rapid tumor progression, and you want to have a decrease of the tumor burden. Some patients. For the others, clearly I have no over argument to choose between one and other.
How do you do that in Freiburg?
Well, more or less the same answer. The TML strategy is clearly a very smart strategy for those who had a benefit from a first-line bevacizumab-based combination regimen, were progressing immediately under treatment or after a longer treatment duration, and then we just change the second-line chemotherapy and continue bevacizumab. However, if we don't have this information from patients from first line and they're not following this sequence, then of course, and if they are symptomatic especially, then they need the most active treatment.
And in the RAS wild-type patients, in a RAS wild-type patient where you decided in first line to go for bevacizumab, he comes in second line, would you choose for an angiogenesis inhibitor or would you choose for an anti-EGFR antibody?
Well, personally, I think these patients do need an anti-EGF receptor antibody at some time in their career with the disease. But this could also be if they fail the second-line treatment, which would also then include an anti-VEGF treatment agent. So I'm personally a fan and also a believer in this continuum of care of anti-angiogenics throughout treatment lines. So maybe, and there I'd like to know your take, is maybe also the multi-kinase inhibitor in third lines are some of the X chemo, Y second line chemo, Z maybe the other tyrosine kinases inhibition in combination with anti-VEGF. So for me this is also in this continuum. What is your...
Yeah, for me the continuum of care is important, and another statement that is important also is the fact that if you look at the activity of anti-EGFR antibodies, it's at least as high in third line as in second line.
Yeah.
So in this concept that brings back to, if you look in the ESMO guidelines, the recent guidelines of ESMO 2014, with the different scenarios, in the first scenario, you have 4 lines, 4 options, chemo plus bevacizumab, chemo plus an anti-angiogenic agent in second line, the anti-EGFR in the RAS wild type in third line, and then regorafenib in later lines.
Yes, I agree. And
but it's clear that we need clearly strategic trials.
I think the choice has to be done in first line.
Yeah.
That is the most important. The strategy has been to be done in first line.
So the concept of the continuum of care, as we said.
And for wild type, either you choose to use anti-EGFR in first line,
or in third line.
Or in third line.
Yeah,
I agree.
Yeah. Yeah, I think that brings some nice messages, and that brings us to some conclusions. That it seems that there is quite a good consensus. We agree that we have made progress, that angiogenesis inhibitors are very important. We have important data in first line. We have very important data in second line with 3 agents available, 3 angiogenesis inhibitors available in second line. Not big differences in activity in cross-trial comparisons. So we need to have them in our fingers. We probably need the different agents. There may be a place for the different agents in second line also. The future, of course, we hope to find a biomarker also. But that's a general statement. I'm not sure that we will find one for this that differentiates the antibodies. It's even unlikely that we will find one. But that we take our decision on what is the goals of the treatment, symptoms, eventually a patient to convert him to resection. The duration of first line may influence the choice in second line. In some patients, the RAS status also, although it seems that many of us, if a patient was treated in first line with an angiogenesis inhibitor, we would go for the EGFR inhibitor in third line instead of second line. So that brings a kind of rationale of what we're doing, and also support of what is presented in the different guidelines, such as the ESMO guidelines that we are further refining after a recent consensus meeting. But it shows that the field is rich. It shows that we need more strategic trials, that we need to learn more. And that's some of the important aspects that we discussed with you, and I'm very happy that we could discuss, and I'm very thankful to you, Mark and Dirk, and also Imedex for organizing this and giving us the opportunity to discuss this freely during this debate here in Leuven. Thank you very much.